Good morning, everyone. Thank you for coming today. I think we're about to start the webinar as well. Do we have that up and running? We're all ready to go, and I have to thank all those people out there. So when we're ready, let me know. Okay. Good morning, and welcome to today's briefing and panel discussion, Integrated Primary and Mental Health Care, Reconnecting the Brain and the Body, brought to you by the APA and its commissioned release of the Milliman report. Before I start, I need to just tell a quick little joke so we get it out the way. If you're worrying about my accent or thinking where it's from, it is from California. And if you're from California, it is Northern California, because that's where I did my training. But all kidding aside, it is originally from South Africa, but I now consider it American, although when I go back to South Africa, they hear it as American, and you here apparently hear it as South African. So with that out the way, let's proceed. Today, as the national debate once again relooks at mental health care, heightened by the Fort Hood tragedy, this makes today's discussion even more important. Debates about violence and mental illness is not the debate we should be having. Rather, access to care, research, finding funding for prevention, early intervention, and treatment with recovery wraparound services is what we should be discussing. I hope this event will help the nation and our administration and congressional leaders begin the discussion based on facts and science. My name is Dr. Saul Levin. I'm the CEO and Medical Director of the American Psychiatric Association. I want to thank you all for making time to be with us here today to discuss integrated behavioral and primary care models. And thank you to everyone joining us using today's live webcast. I know there are quite a few, and it's growing in numbers, of our members and district branches watching, and we're glad each of you have made the time to join from afar for the important discussion. There is an unprecedented amount of attention being paid to our nation's healthcare system. In the midst of debate about how to lower costs and improve outcomes, mental health care has increasingly become the focus for discussion for reform. Most recently, we saw this in the release of the final rule for Mental Health Parity and Addiction Equity Act of 2008, commonly called MAPIA, creating a momentum to improve the quality and access to care. But this momentum is accompanied by an increased necessity and commitment to sustainable change in how we deliver and pay for care. It has also provided us an opportunity to reconsider our models of care and think about how and where we provide behavioral health care for the people with mental health and substance use disorders. Integrated care models are one of the solutions to help expand access to quality care, leverage limited healthcare resources, and provide patients comprehensive care. They show promise for improving the quality of care and reducing the barriers to health care for those who have long faced discriminatory hurdles in getting the services they need and deserve the essential components of this approach is collaboration. In integrated care, psychiatric physicians, primary care physicians, and other mental health clinicians work together with the patients and the families to truly provide patient-centered care. This approach of integrated care utilizes a systematic and cost-effective approach to providing patient care. As you hear today from a variety of experts, these models have been shown to address a range of areas, including mental health and substance use disorders, chronic conditions, and health behaviors, and last but not least, ineffective patterns of healthcare utilization. I'm pleased to have such a distinguished group of presenters here today to discuss these models. Dr. Jeffrey Lieberman, my president and our president of the American Psychiatric Association and chairman of the Department of Psychiatry at Columbia University, will speak to the growing body of evidence supporting these models. Dr. Michael Hogan, the former commissioner of the New York State Office of Mental Health, will deliver the keynote remarks. Dr. Paul Summergrad, my president elect of the American Psychiatric Association, and chairman of the Department of Psychiatry at Tufts University School of Medicine, and psychiatrist-in-chief of Tufts Medical Center, will present new findings on the benefit of these models. Relative to this event, he has also chaired the APA ad hoc committee that developed the report, The Role of Psychiatry in Healthcare Reform, that we will discuss today. But we're also fortunate to have two expert panels, including healthcare economists, primary care doctors, behavioral healthcare professionals, and advocates. I know we're all looking forward to the presentation, so this time I'd like to turn over the floor to Dr. Jeffrey Lieberman, President of the APA. Dr. Lieberman.
Good morning, ladies and gentlemen. It's really a pleasure to be here on this day, which I hope will sort of signal the start of something which has a transformative effect on the way our country delivers health care to people. There's adages that everybody is familiar with, such as there's no health without mental health. And the other one that I've heard, which I'm fond of, is the secret sauce to healthcare reform is mental health. And the key ingredient to that sauce is collaborative care and integrated care. And so, hence the title of this forum today, which is Reconnecting the Brain with the Body. As I think everybody in this room is aware, the epidemiology of mental illness is very substantial. Conservatively speaking, a quarter of people within their lifetime will have a mental disorder. Many of these conditions co-occur along with non-psychiatric medical disorders and occur in the setting in which people are getting medical or surgical services. However, given the fragmentation, the separation of our services and our provider delivery systems, they're often separated, and therefore the comorbidities don't go untreated, whether it's psychiatric comorbidity in individuals receiving medical or surgical care, or whether it's the medical comorbidity in individuals with mental illness receiving mental health care. Psychiatric training instills in doctors who choose to pursue psychiatry a specific set of skills to try and integrate understanding of the brain and behavioral disturbances with other physical conditions. Treatment by psychiatrists as part of the overall health care process really contributes to better patient outcomes and to improve healthcare resource utilization and ultimately cost effectiveness. So it's natural that we should consider how we can find a more efficient and more cost-effective way of integrating psychiatric and mental health care into general health care. The truth is, though, our workforce is not necessarily configured and deployed in an optimal way. Many places, because of lack of adequate numbers of psychiatrists, mental health providers, or geographic maldistribution, there's no psychiatrist to cover large populations or large areas in the country. More than half of the counties in the U.S. don't have a single practicing psychiatrist. And at the same time, research shows that 40% of patients with mental health problems initially seek care, or the first line of contact is in the primary care system. Talking to my colleagues, Frank and David, in family practice and pediatrics, 40% may be an underestimate. So this is a natural area for collaboration between psychiatrists and physicians, and particularly primary care physicians, to ensure that behavioral health becomes an integral part of overall health and vice versa. Now, this is not just a kind of platitude that I'm mouthing. There's actually a substantial body of evidence which supports this. Of course, Health economists and policy experts like Richard Frank, Mike Hogan may have the final say on this, but I'm hoping that they'll agree with us on this, that the evidence is very compelling. The studies have shown that concurrently treating behavioral and physical conditions not only leads to better control of the illness itself, but also better patient satisfaction, quality of life, and reduction in healthcare costs. The Cochrane group, which does these massive statistical analyses and meta-reviews, has reviewed close to 80 randomized controlled trials of integrated care, including more than 24,000 patients worldwide, and have found that collaborative care was more effective, particularly in terms of patients' subjective experience, satisfaction, quality of life, and in ultimately the cost of delivering care. As we'll hear from our panelists, similar results are being seen throughout the country. And I'd like to think that this model, if not the idea, is spreading like wildfire. Right now, we treat medical and mental illnesses as if they're in separate domains and they can be compartmentalized, but we all know that that's not the case. So your presence here, I think, indicates the fact that you and the organizations you represent have a sincere and enthusiastic interest in this area and a commitment to seeing this idea and model of care be embraced and integrated into our healthcare system. And it's dependent, our success in being able to do this is really dependent on us working together. No single discipline, no single constituency can do it alone. But working together, we really can take something which is gestated conceptually, been vetted through demonstration projects, and accrued a confirmatory body of evidence, and roll this out and integrate it into our care system with what we hope will be tremendously beneficial effects. So to get started, it's my great pleasure to be able to introduce our keynote speaker today, somebody who I know not just by reputation as one of the foremost mental health care administrators and policy experts in the country, but also as somebody who used to be my boss, but I still defer to him very deferentially, even though he's not formally so. But Dr. Mike Hogan served as a number of capacities, including as the state mental health commissioner or director in Connecticut, Ohio, and then most recently in New York. And he also was the chair of President Bush's Presidential New Freedom Commission on Mental Health, the last presidential commission to really take on this issue. In leading New York's public mental health system, he led the largest and most generously funded per capita basis of any public mental health system in the country. So please welcome Dr. Michael Hogan.
Well, thanks, Dr. Lieberman. It is really good to be here on this issue, and my assignment is to try to underline why this issue is timely, why it's important, and why this approach to integration is right. I want to commend the leadership of the American Psychiatric Association for this event and all the work that's gone into it, and for this position. It's a little bit unusual, in a sense, for a specialty medical organization to be talking about care that's primarily in the mainstream, as opposed to care entirely in its specialty. And I want to underline that point, but it is so crucial. Let me start a little bit with the timeliness of this issue. We are in an era now where it might be like global warming, where the movement of people with or concern about psychiatric conditions into mainstream healthcare is overwhelming. Yet we still behave as if the quote-unquote mental health system was a separate and a solution to these problems. Interestingly, the American Psychiatric Association was founded in the middle of the 19th century as an association of physicians who led the asylums that were the primary approach that our country used at that time to treat these conditions. But we've come a long way since then. with the enactment of Medicare and Medicaid, and with all the changes, particularly in the last half century, these conditions are now much more significant in the mainstream. So one way to sum this up is to say that the specialty mental health system is neither the problem anymore, nor the solution to the problems of access to care that so many people are faced with. It remains very important. So steps like the Excellence in Mental Health Act that was included in the Doc Fix bill are very important because they're going to help stabilize and sustain that specialty mental health system. But that's not really where most of the challenges are anymore. The challenges are in primary care offices, in hospitals, but not necessarily in psychiatric units, in home care, but not necessarily in special mental health programs. And this change that has moved us into the mainstream really is of overwhelming force. One of our panel members, Richard Frank, wrote with Sherry Gleed the best summary of recent history of mental health care in the United States. And they looked at the changes over the last 50 years, concluding that, as the title of the monograph illustrates, the well-being of people with mental illness is better, but not well. And interestingly, the main force that they discovered that made things better was the access of people with mental illness to mainstream benefits. The fact that health insurance had expanded, the disability benefits had expanded, that there was new access to care. Those developments were more helpful in sum to people than improvements within the specialty mental health system. And I want to illustrate the significance of the problem of integration in a couple of different ways. The epidemiological evidence now suggests that the average time lag between first having some symptoms of a mental disorder and first getting professional care is 9 years. In the United States of America, in the 21st century, the lag is 9 years. And since the average age at which people experience a mental illness for the first time, if they're ever going to experience it in their life, is 14, this means that this long lag time of things deteriorating, of getting worse, of not getting care, takes place during adolescence, which is a really bad approach to things. So we have this very long lag time that exists. People, if they go see anyone, are much more likely to see some variety of a primary care physician. And as we hear from some of our colleagues and leaders in different primary care disciplines, primary care is already slammed with these problems. Except for flu season, pediatricians have more visits where the chief complaint is behavioral than any other category of visit. In family medicine, Frank DeGroy would know the precise numbers, but upwards of a third of all the patients coming into family practice physicians have got some kind of a behavioral complaint. But without the tools to deliver good care there, the problem is likely to be put off. And we know a lot about what happens when we don't have integrated care. That is, when we don't have a team that is working together. If you walk into a disintegrated or an unintegrated primary care office, unless your practitioner is very tuned into these issues, with depression, your chance of getting a diagnosis is about 50-50. And if you get a diagnosis, the chance that you're going to get minimally adequate care, that is enough of something the research has said will make a difference, is 50-50. You add all that up, it's about a 1 in 5 chance that you're going to get relief from what may be the single thing that brought you in that day. This can be fatal. Multiple studies now point out that half of the 38,000 people who die by suicide in the United States every year, the number is probably more than that, except our statistics lag so badly that we don't know yet. 38,000 was the number of people who died by suicide in 2010. Half of those individuals have seen a primary health physician within the 30 days prior to taking their life. But our de facto policy has been don't ask, don't tell. It is not a good approach to these problems which can be crippling or fatal, but can also be very treatable. The lack of integration is also a problem over in that specialty mental health system, where we tend to treat this part of the body and ignore the neck down. And so integration there is also really important to help address the fact that people who are actually getting care in the mental health system are dying on average 25 years before their life expectancy, mostly from cardiac problems. So integration of care in the mental health system is also really important, but it's not our primary concern here today. Our primary concern is on the much larger problem of integration in primary care. The report that Dr. Summergrad will present makes it clear also that there's a huge economic consequence of the failure to integrate medical and behavioral care. About a third of the people who have got any kind of a chronic medical illness, COPD, asthma, diabetes, and so on, are also living with depression or some other common and treatable mental health problem. And I can remember my mother's experience with this when she was alive. She dealt with both diabetes and depression. And it was just crystal clear that when she was managing her depression, she would manage her diabetes. When she stopped taking, as she called them, her shrink pills, she would stop monitoring her blood sugar, and really bad things would happen. It was just such a simple and direct relationship. For the 1/3 of people who have a medical illness who also have a behavioral health problem, the report that will be released today indicates that the total costs of care are doubled. And the costs of care are not doubled because they're using a lot of mental health care. The costs of care are doubled because of excess use of medical problems, like I illustrated, or excess use of medical care of situations like I described with my mother. That's just an example with chronic illness. We also have this problem in hospitals, where a third of the people who are in a hospital bed in the United States today, not for a psychiatric problem, but for a medical problem, also have depression, anxiety, some other treatable mental health challenge that, if addressed, would help them cope with their healthcare problem. It's unlikely to be detected. It's unlikely to be treated. They will stay, on average, a day longer in the hospital because of the failure to address and treat the behavioral health problems. And if you looked at a hospital bill, an extra day in the hospital is not inconsequential. And then when they get out, their chances of readmission to the hospital or of going to the emergency department for care are also greatly increased. So we need integration in primary care, we need it in inpatient care, we need it in aftercare. The other reason why this issue is timely and important, as Dr. Lieberman said, is the jury's now in that integrated care is effective. Now, integrated care is not like deinstitutionalization. You know, it's not hoping. It's not shift and shaft. It is taking concrete steps to put teams together to do this work. And as Jeff said, the approach that's labeled collaborative care is probably the best documented and best proven approach. So you have a mental health specialist of some kind, a social worker, a psychologist, a psychiatric nurse, who is on the floor with the medical team, available so that if the physician is seeing one and has concerns about depression, they can say, I'd like to ask Mrs. Smith to come down and join us. I think she can be of help to you in talking about this. If you decide you want a prescription to deal with this problem, I can prescribe that, but she can talk to you about how to adjust your life, how the medication will affect you, arrange other services if you need. So there is a warm and immediate handoff to care, which is going to be effective, as opposed to a referral to somebody on the other side of town where there's a waiting list, where you're not certain you're going to go there, and where in more than half the cases, the referral is going to land with a thud and there's not going to be follow-up. So collaborative care means having somebody on the floor. It means measuring what we do and seeing if people are getting better. And it means having a psychiatrist available to talk, usually by phone, with the treating physician or with the other mental health specialists to bolster the work that they're doing. And as Dr. Lieberman said, 80 randomized controlled trials now, and those research studies prove not only the effectiveness of collaborative care, that is, your mental health gets better, your medical, physical health gets better, and the total cost of your care goes down. You know, can we find other examples where an intervention has so many positive outcomes? The reason for the importance of this report is that doing this is proven, but it's not easy. There are still obstacles to integrated care. In one of the pages of that 2003 report of the President's Commission, there's a recommendation that Medicare should pay for the cost of collaborative care, and it still hasn't completely happened. I will say that Medicare has taken a lot of steps forward, but for example, there is still not a payment approach to pay for the psychiatrist to do the telephonic consultation. Another example of an obstacle is that a lot of us have our insurance set up with our mental health insurance in one plan and our medical insurance in another plan. These plans each have their own sets of providers. The nurse or the social worker or the psychologist who's in the primary care practice may be credentialed and able to be reimbursed in a limited way on the medical side, but they need to do mental health procedures as well. So separate insurance plans get in the way of this. Competing medical records get in the way of this. So the work of integration, although the mandate is crystal clear, is hard, and that's why I'm so appreciative of APA's leading on this issue, and why I'm so hopeful that those of you in the room and those of you who are watching will go forth to call for this and to work on it, because as with so many other issues, a report is important, but it's not sufficient. It's going to take us all to roll up our sleeves. I want to, with those sort of level-setting comments, turn the podium over now to Dr. Paul Summergrad, who, as Saul said, is the president-elect and has been quietly leading on these issues within the APA for some time.
Thank you very much, Dr. Hogan. And I want to thank all of you for being here and all of you who are joining us by the webcast from across the country, state associations, district branches of the American Psychiatric Association, and others. We're pleased as the American Psychiatric Association to release these two reports today, and I want to give you the context and the background for the work that we did. So we are releasing today two reports. One is the role of psychiatry in healthcare reform, which was the work of an ad hoc work group of the American Psychiatric Association Board of Trustees. And the second is that committee, that work group, commissioned an external report by Milliman, the global actuarial and consulting firm, to really help us look and see what are the costs, not just of mental health services, but the costs of medical care services as well for individuals who have psychiatric and substance use illness compared with individuals who don't have those costs. So we can understand the many impacts that psychiatric and substance use care has. Now, there are lots and lots of reasons for all of us to move towards people who have mental health and substance use illness. There are our brothers and our sisters, there are our parents, our children, there are ourselves, and people are suffering and people's lives are tragically affected by untreated and uncared for mental health and substance use illness. One of the other, though, hidden effects, and especially as we think now around healthcare reform, is around the impact on the total cost of care and people's combined medical and psychiatric care. So that's what we focused in on in this work. And today we're also going to talk about the triple aim and the way this works within the framework of the triple aim. So healthcare reform's triple aim is to look at improving the patient care experience, it's improving the health of populations, and it's reducing the per capita cost of healthcare. And these are principles that have been enunciated for all of healthcare, especially as we're trying to develop patient and person-centered healthcare that's organized around the needs of individuals, not the needs of the healthcare system per se. As we began our work within the American Psychiatric Association work group on healthcare reform, we felt that we needed some external work. So we turned to Milliman, and we really wanted them to look with us at what is the economic impact of integration. And we're releasing today for the first time the results of this report, which you have, for those who are here in the room, on your thumb drive, and will also be released online by the American Psychiatric Association. This report looks at individuals who receive mental health and substance use services and medical care services either through commercial, Medicare, or Medicaid insurance. It includes utilization and cost data from millions of patients, then extrapolated to the entire US population. And it compares data both from those with chronic medical conditions, with behavioral health conditions, and those who have chronic medical conditions alone without coexisting behavioral health conditions. So what did we find? About 14% of individuals who have insurance use mental health and substance use services, but their total costs in the total healthcare system, looking at all medical and psychiatric care costs, but especially affected by medical care costs, is over 30% of total healthcare spending in the United States. What that means is that general medical care costs for people who have behavioral health disorders were found to be 2 to 3 times higher than those without behavioral illness. When we quantify this further, the expenditures that Milliman found under insurance for mental health and substance use services directly were $92 billion a year. But the additional costs that were incurred by people who have behavioral comorbidities across all insurance types was $293 billion a year, over what it would be for those individuals who don't have mental health and substance use services. And this was not something where people were going and seeing their doctor all the time. It was really the place where the increased costs were most dramatic were in emergency room utilization and facility costs, people getting admitted to a hospital or coming to an outpatient center for emergency care of some type or another. And of that $293 billion, the vast majority is related to medical surgical costs, not psychiatric care costs. We also asked Milliman to say, if we look at the work that Dr. Hogan was describing and Dr. Lieberman was describing, the work that really describes what is collaborative care, what's integrated care, what does the research data show, and if we were to extrapolate that, not as a promise today, but as a goal to strive for, what kind of impact could we have financially on the healthcare system? And their estimate was that we could save between $26 and $48 billion annually in general health care costs, again, predominantly associated with general medical care costs. Now, this is something that's going to need more work and more research to see whether that's really true. We need a lot more work, as we'll talk about in terms of the findings of this report. But to summarize this work, it's essentially to say that mental health is not just important because of the human suffering that's involved. That's the most critical reason why it's important. There's too much pain and too much suffering going on in too many communities in this country. But it's also important because it's simply too large to ignore. It's too large in our prisons, it's too large in our jails, but it's also too large in our healthcare system and in our total general medical care cost of care. And it's something that we need to acknowledge and we need to find a better way of dealing with. So as we looked at this in terms of our work group report, which you also have, which is really around the role of psychiatry and then more broadly the role of behavioral health in healthcare reform, we looked really at 6 key areas. Contemporary reform efforts, what are people doing? What are the models for integrated care? How do we finance care? What are quality and performance measurements? What are we doing about health integrated technology, information technology, EMRs? And what are we doing about our workforce? And that workforce is not just the mental health workforce. It's really the general medical workforce, because we know from every possible study that the vast majority of care that's provided on an ambulatory basis for individuals with mental health and substance use is provided by primary care physicians and in the general medical sector. That's always been true. It was true in 1978. It's true now as well. So what did we find? And there's much more detail, again, in the reports that you have available to you. First, in terms of contemporary reform efforts, we need to be monitoring new models of care and making sure that we're enforcing both parity and compliance with other existing regulations, and it's going to be critical to make sure that we have a monitoring capability to know what's happening with healthcare reform as it relates to mental health and substance use, and that all behavioral health providers must play an expanded role in integrated behavioral and medical care. And that's also obviously true for all of our colleagues in general medicine and primary care. Secondly, around integrated care, we need more research to build the evidence base and to explore the financial impact and to define roles of all providers in providing this care most effectively. And psychiatrists, along with primary care physicians and other clinicians, both mental health clinicians and other clinicians, have a key role to play in providing integrated care solutions. We don't have enough people that we can waste anybody in this effort. We need everybody who's not only in this room, but listening and working together on these issues across the medical and the behavioral spectrum to work on this. In terms of financing of care, we need to find ways of moving towards integrated payment issues, integrated payment for care, so that we're not creating separate buckets which says this occurs in one universe, this occurs in the other universe, and the two will never interact with one another. At the same time, we need to be very careful to protect fragile behavioral health budgets, which have already been under pressure from a whole range of directions, both from economic and insurance and state government cutbacks. And the payer and systems must include behavioral care in broader budgets, and those budgets need to understand the impact of not including behavioral care within them. On quality and performance measurements, there needs to be more aggressive development of performance measures. We need to identify priority areas with clear metrics for success in specific areas, and we need to look at it not just in the framework of mental health and substance use care, but the impact on the total cost of care and the total quality of care. In health information technology, despite the challenges, successful integrated care depends upon electronic capabilities, which will allow people to crosstalk across medical and behavioral health systems. That's going to require investment, and it has to be a priority for the field, for patients, for policymakers and the public. And at the same time, we have to think very carefully and courageously about how we deal with issues of both confidentiality, but the need to make sure that the right information is available for the right patients at the right time, so they're getting the care and the services they need. In regard to our workforce, without workforce changes, there's going to be difficulty meeting the demand for specialty services, and we need to provide enhanced training across the entire healthcare team. This doesn't mean just for individuals who are mental health providers or psychiatric physicians. It means all physicians, nurses, caregivers who work with patients and their families. So we are proud to be able to present this work. You have much more detailed versions of this. But we think that there is a compelling case to be made that mental health and the problems associated with it are not just too important to ignore because of the human suffering that's associated with them, which we're all familiar with, but also because there's no way we're really going to deal with the total issues around healthcare costs, unless we reach out to everyone and reach out across the mental health and general medical domains and make sure that we're all working together to provide that care. So what we'd like to do now is to shift to present a panel on this. And stepping back from these findings of the Board of Trustees Work Group on Healthcare Reform, we're joined today by a diverse group of healthcare leaders who will have broad resonance and support for integrated care. And I'd like to introduce them, and if they could come up and grab seats. John O'Brien is the Senior Policy Advisor in the Center for Medicaid and CHIP Services in the Centers for Medicare and Medicaid Services. Dr. Richard Frank is the Margaret T. Morris Professor of Health Economics at Harvard Medical School. Dr. Frank has also been nominated by the President to be the Assistant Secretary for Planning and Evaluation in the U.S. Departments of Health and Human Services. Dr. Michael Schoenbaum is a Senior Advisor for Mental Health Services, Epidemiology, and Economics at the National Institute of Mental Health. Dr. Eleanor McCants-Katz, who's Chief Medical Officer for SAMHSA, for the Substance Abuse and Mental Health Services Administration. And Dr. Hogan will be joining us as well. So, John, if you could start the discussion, we'd appreciate that.
Terrific, and thank you for inviting us, and congratulations on the release of your report. We think that that is critical information, not only for the work that we're doing, but certainly for the work that the fields, plural, are doing in this particular area. The Affordable Care Act did provide the Centers for Medicare and Medicaid Services with a number of opportunities to work closely both with payers and states, and in some cases with providers around integrating primary care and other chronic conditions, including behavioral health care. The program that I'd like to highlight really is our Health Home program, which was Section 2703 of the Affordable Care Act. It's the program that we have a lot of traction on over the last 3.5 months. We have been lucky to work closely with states, and we've been very lucky to work with SAMHSA, who is our partner in crime in helping us work with states in this particular space, as well as ASPE, who's helping us with the evaluation. So the overall vision for Section 2703 of the Health Home program is that we wanted to see enhanced coordination and integration around 3 sectors, not only just primary care and behavioral health, but also including long-term services and supports, because a number of persons with chronic conditions, including mental health and substance use conditions, do need and do use long-term services and support, and we felt that that was critically important. Our goals for the program are fairly straightforward. Obviously, one of the things that we wanted to pay particular attention to, especially for some of those chronic conditions that were not specific to mental health or substance use, was identification of whether or not individuals with that chronic conditions did or did not have mental health or substance use conditions. As Mike pointed out and others pointed out, that having a chronic condition really does put you at a higher risk for having a mental health and or substance use condition as well. Some of the other goals were certainly some of the reductions in hospital inpatient use, as well as emergency department use, less reliance on long-term care facilities, because we think that's an important equation as it relates to Medicaid, since we are some of the primary payers for long-term care. Just a snapshot of the Health Home program. Obviously, it is focusing on individuals that are Medicaid. In order to be able to qualify for entry into a health home, you have to have chronic conditions. You either have to have 2 chronic conditions, and I'll talk about those in a second, a chronic condition or at risk of a chronic condition, or if you have a standalone condition of a significant mental health condition, a health home can be created by a state around that particular condition. Many of the conditions that are included in the statute around health homes are similar to what you see in the report. Certainly, chronic conditions as it relates to asthma, diabetes, heart disease, and overweight, as well as substance use disorders. The services that the health home provides really falls into a couple buckets. One is making sure that there's good care coordination, coordination across all 3 systems that I talked about. In addition, making sure that the transitions between inpatient as well as community services, or even nursing facilities or group homes or substance use residential treatment facilities to outpatient services is done and is done well. We also allow, as part of what's offered under the Health Home program, to ensure that there's good individual and family support, and we leave it up to the states to be able to define what individual and family support is, and so we encourage them to think a little bit more broadly about what that looks like. We have 22 approved state plan amendments in 14 states, and we take our time, and I don't mean that in a facetious way, with the states, working pretty closely with them and with SAMHSA to really identify what are the models that they're looking to use, and whether or not those models are tested models, or whether those are models that maybe we're interested in seeing some testing. There are a number of lessons learned over the last 2.5 years. Happy to say we're now approaching the graduation of some of our early states. This was a program that was not limited to 2 years, but our enhanced financial contribution was limited to 2 years. And one of the things that the states are doing are leveraging existing programs, whether that be some primary care programs that had behavioral health embedded in them, community mental health centers, or substance use providers that wanted to and have now embedded primary care into their practices. They're also, the lessons learned is, not surprising, there has to be some really good leadership in a particular state to want to do this, number one, and then to want to do it right. Obviously, certainly the states that have come forward the first typically have those the leaders that want to do that. We also have, some enhanced focus on individuals with substance use disorders. As of January 1st, we have 25 states that are now including the expansion population, many who have a substance use disorder, and now states are beginning to say, well, gosh, we think that this is a really good opportunity to think about the health home approach for this particular population as well. We've got some information from the first round of states that were participating in the health home program. Certainly, we have seen a reduction in both hospital admissions. So for Missouri, we're seeing almost a 13% decrease in hospital admissions in Missouri. In this particular case, was focusing primarily on individuals with behavioral mental health conditions. We're also seeing emergency room use by these individuals in Missouri decrease by a little over 8%. And in New York, while it's fairly preliminary, we are seeing spending for inpatient services overall for their proposed or their health home proposal decreasing by about 30% on the inpatient use side. So we're very pleased with what we're seeing. As we move forward, we will probably have more data to support some of what you have in the report.
Thank you very much. Just for all of you, we have note cards at your table, so if you'd like to submit questions and answers, we will be collecting those with our staff for a question and answer at the end of the panel discussion. Richard, would you like to go forward?
Thank you for inviting me to participate in today's discussion. First of all, I'd like to congratulate the APA for producing a report actually that has a great deal of wisdom to it, and I hope my remarks are complementary to that. In the time I have with you today, I'd like to touch on 3 questions. The first one is, what are the potential economic benefits of adopting policies that promote greater integration of behavioral health and general medical care? The second one is, what opportunities are there in the Affordable Care Act beyond the health homes that offer the opportunity to promote integration more so than in the past? And then third, what gets in the way of implementing what has been shown to work? Let me begin with the cost effectiveness issue. One of the key issues is, are we producing better health care efficiently? And that's better mental health care and also better general medical care. And that's sort of fundamental to today's policy imperative. And in a review of about 37 randomized studies, Sherry Gleed and I put together all the information on the cost effectiveness of the collaborative care programs, and we found that virtually all of them that have been studied have produced quality adjusted life years, which is sort of a standardized measure of outcome these days, for less than the American standard of efficiency, which is $100,000 per quality adjusted life year. Turns out the vast majority also produce collaborative care programs also produce quality adjusted life years that meet the British standard, which is far more stringent, of $25,000 per quality adjusted life year. Let me emphasize that does not mean that there are cost offsets. This just means that the collaborative care model promises clearly value for money. And at least in my world, that's pretty good by itself. The evidence base on bringing primary care into specialty behavioral health settings is less well developed than it is for collaborative care. There have been relatively large-scale implementation demonstrations that have relied on both experimental and quasi-experimental methods to evaluate them. The studies are mixed with respect to both outcomes and cost effectiveness. However, on a more optimistic note, there have been some recent demonstrations in Pennsylvania and in Washington State that point to the potential for not only improved well-being of people, but also cost savings. Yet integration in these cases extends generally far beyond just behavioral health care and general medical care, and typically includes things like housing, employment supports, education supports, transportation, and the like, human services writ large. Let me now turn to the Affordable Care Act. The Affordable Care Act places some important bets on policies to promote integration. At the heart of delivery system reform under the Affordable Care Act are new institutions that promote integration, either explicitly or implicitly. John talked about the Medicaid health homes. But in addition, there's the integrated care demonstrations for duly eligible beneficiaries for Medicare and Medicaid that explicitly focus on sort of evidence-based models of integration. The implementation and extension of the Mental Health Parity Act also promotes integration. Less explicit, but of tremendous import, are the new institutions that have been created under the Affordable Care Act, such as accountable care organizations and patient-centered medical homes, both of them in the Medicare program. In each case, more services are being organized, put together under a budget, and given to clinical organizations to manage. And to a large extent, many of these efforts are being guided by the design of evidence-based programs, of the evidence that we've gotten from research studies. In addition to those efforts, the Affordable Care Act established a grant program in SAMHSA that has resulted in over $100 million being directed towards supporting integration of primary care into behavioral health settings. I'm sure you'll be talking about that. So I hope so far I've persuaded you that integration efforts have considerable potential to efficiently improve outcomes, and that the ACA creates opportunities to expand those efforts. Let me now touch on what I see as some of the threats and barriers to getting the job done. And I'm going to talk about three. First are incentives. Second is behavior change. And third is attitude. Usually attitude is not the domain of economists, but I'll take the liberty today. Let me start with incentives. The new institutions at the center of this, as I mentioned a second ago, are organizing services, integrating services under a budget. And that does two things. It creates tremendous new clinical flexibility to devote resources in ways that are not sort of defined narrowly by narrow benefits and narrow structures. At the same time, having services under a single prospectively set budget creates incentives to do less. Now, those incentives to do less are typically offset by measuring quality and attaching quality to payments or shares in savings. The degree to which cost-effectiveness integration is implemented in things like ACOs, integrated care organizations, and health homes will depend on the extent to which those mechanisms, those quality measures, are used to hold those organizations accountable for doing the right thing. Now, the quality incentives across these programs are quite mixed. Some have made very serious efforts, and some of them have been much more limited. Now, this is in part due to the state of behavioral health quality measurement, as we heard earlier, practical matters of implementation, and then the inevitable positioning of different competing concerns at the onset of a new program. The bottom line is rewarding benefits of integration is key to making integration happen. Let me turn to behavior change. Working in new institutions that are adopting new practices requires practitioners to change, and change is hard. Nearly all models involve expanded use of health information technology, which means making required investments and changing practices so that you can take advantage of the opportunities afforded by access to information technology. It's also involving clinicians to work in teams in a way that's very different from what has traditionally been the case. That all means that changing organizations, changing the organization and the practices of many clinical organizations. Now, evidence from state efforts to integrate health and mental health care shows that there are significant impediments to integration from all of these and trying to kind of get this thing done. Finally, the evidence from evaluations of integration programs that bring primary care to specialty behavioral health settings indicates that implementation of the elements of evidence-based care has been quite uneven. Programs appear to pick and choose what they think is the right thing to do, and they're not sufficiently mindful to how all the pieces fit together. Here, the bottom line is fidelity matters. And the more you drift away from what is known in combination to work, the less likely you are to get the desired benefits. Let me hit on attitude. Case studies of integration show that advocates and some staff are resistant towards integration because of concerns over medicalization. This is in part an attitude problem. It's also in part a program design problem, but they have to work together. Clinicians are often resistant to health information technology aspects of integration, in part due to concerns about privacy. The question here is, have we got the balance right between privacy and doing the best we can for people? Accompanying that resistance is a resistance to communicating with other professionals. Even when affiliations are in place between behavioral health and primary healthcare organizations, the development of things like joint treatment plans are the exception, not the rule. Shared decision-making among professionals has been frequently noted as a barrier to successful integration, but the barrier is seldom resolved as you follow up the progress of these rollouts. So in concluding, I think we're at going back to what Mike said, I think we're at a moment for improving how this country addresses behavioral health that we haven't seen in quite a while. There's greater know-how today about how to make integration work than ever before, and there are critical new opportunities for making it go. There are also threats and barriers that I've sort of ticked off, and the challenge is there for all the stakeholders, policymakers, professionals, consumers, and payers. Much of what needs to be done is clear. It's not mysterious what goes right and what goes wrong. So it's what's going to be important to make the most of the opportunities is having the energy, the leadership, and the political will to get the job done and to make the most of the moment. Thanks.
So our next speaker is Eleanor McCants-Katz from SAMHSA.
Yes, thank you. So I'm going to just speak about this issue as a clinician because I've been at SAMHSA a few months now, but I came from the clinical world. And so it's not hard to understand how the costs for individuals who have co-occurring mental illness and medical illnesses are much greater, and that, of course, is very nicely documented in this Milliman report. But let me just tell you a little bit about what it's like for physicians and patients to try to navigate the current system. I'll just give you a couple of examples of patients that I've worked with. For example, a patient with schizophrenia, a disease or a disorder that can cause someone to have problems with their thinking and their ability to organize. And that person may need medical care. It's very hard for them to get across town to another appointment. And so they often don't get that care they need. And it's very hard for those of us working with them in a mental health setting to help them get to those appointments in the current system. In working with patients who have substance use disorders, a not uncommon scenario that I've run into is a person who has opioid dependence and is being methadone maintained, who has hepatitis C and needs to get treatment for their hepatitis C, and trying to work with gastroenterologists who believe that person's still addicted and won't treat them. Colleagues in primary care who would tell me, because I did some work in our primary care programs at the last university I worked at, they would tell me that they would have patients who they would try to treat, for example, for their depression and anxiety, patients not responding, and it would take them months to get them into an appointment in our psychiatry clinics. And that's because these systems are quite siloed and separated. It's bad for patient care. There are lots of costs, aside from medical costs and healthcare costs in general, for those with co-occurring disorders who don't get treatment for all of their clinical needs. And that includes things like housing and criminal justice and juvenile justice and child welfare. These are costs that we haven't thought about with the Milliman report. It was alluded to but not described. These are huge costs that patients face every day when they don't get all of the care they need. So I want to mention a few SAMHSA programs. The Substance Abuse and Mental Health Services Administration has really been made a big investment in this issue for a number of years. We have several programs that seek to improve the care of individuals with co-occurring disorders. We have a program called PBHCI. This is primary behavioral health care integration. And what this program does, a little different from what Dr. Frank was talking about, and less data, but promising data, showing that if you bring primary care into community mental health settings, that you can get improvements for patients, not only in their mental health conditions, but also in their medical conditions. And we have data showing reductions in hypercholesterolemia. We have indication that there are decreases in diabetes and hypertension when people receiving services within community mental health settings also can receive primary care on site. People who have behavioral health issues are often very invested in their mental health program or in their substance abuse treatment program. They should be able to get medical care within those programs. And to that end, SAMHSA is also investing in other types of integration programs. We will be releasing an RFA in a few weeks that seeks grantees who will integrate HIV care into community mental health settings, substance abuse treatment programs. This is a new area for us, but one that has extraordinary need. And we also seek to take the gains that we've seen through our integration of primary care into community mental health settings into our substance abuse treatment programs across the nation, where we hope to bring primary care into the treatment of substance abuse. We also have, as John alluded to, we have a relationship with CMS. We work with a number of federal partners on issues of integration. We do work with the states on their health home applications. Our role at SAMHSA is to talk with the states about how they can think about bringing treatment for behavioral health issues into those health homes that they're proposing. And so we think that this has been really a beneficial program working with our partners at CMS, and a number of states now have the state plan amendment waivers for the health homes. We also have a program that has been very successful. It's screening, brief intervention, and referral to treatment. SAMHSA has invested quite a bit in SBIRT, and we've shown reductions in use of emergency departments and in hospitalizations and in overall healthcare costs for individuals who are screened in primary care settings for hazardous substance use. In addition to that, we have technical assistance programs. We have the Center for Integrated Health Solutions that provides training to clinicians who want to work in the area of integrated care. We have a training program for psychiatrists, for example, who wish to provide services within primary care settings. And the Center for Integrated Health Solutions, if you haven't had the opportunity to see the really broad array of services that they provide to our clinicians, it's really worth looking at. I think it's quite impressive. And so SAMHSA will continue to have a big role in integrated systems and in looking at new ways of integrating care and providing the best care that we can to those who have co-occurring disorders.
Michael.
Thank you. I too want to congratulate the APA for taking on and leading today's conversation. And I want to start with some personal framing too. I'm not a clinician, or in some sense not even a mental health specialist as such. I'm an economist by training. My point of entry to mental health is exactly the interface between mental health issues and general medicine. As one of the principals, I was one of the principals of several of the major trials of collaborative care that my colleagues here have invoked. I'm now at the National Institute of Mental Health, where in truth I could spend my entire professional life on one activity, which is to persuade people or institutions who are focusing on general medical issues, the triple aim that Dr. Summergrad mentioned earlier, that it benefits them and their objectives, never mind us and NIMH's objectives, to focus also on mental health as part of those initiatives. And I'm not exaggerating about that. I could spend my entire life doing just that one activity. I also want to congratulate Milliman on their careful and thorough report documenting the opportunity, the imperative of integration. What I'd like to add, although many of my colleagues have already said many of the things I guess that I would want to focus on here. Anyway, what I'd like to add in this, my part of the conversation, is focus on the specific models of integration for which we have evidence of effectiveness, cost effectiveness, and in some cases, absolute cost savings. Integration means many things to many people. As an aspiration, I think we can all agree that integration is a good objective. You know, it's like being against apple pie. But at a concrete level, we have programs with proven effect, programs that people have tried in all good faith and that were found not to be effective, including, with all respect, some medical home programs, and other programs where the jury is out, either because they're still ongoing or because they weren't rolled out in a way that permits formal evaluation. So what do we know now that works? Broadly, the effective programs, collaborative care, as many people here have invoked, such as the Pathways program, the Impact program, these are both studies that Milliman specifically referenced in their report. They have several core components. The first is proactive care coordination, typically conducted by non-physicians, often conducted by telephone, to educate patients, engage them in initial treatment, track adherence, side effects, and outcomes, and facilitate treatment adjustment as needed. There are various kinds of barriers to that activity actually taking place in practice. Coverage issues, telephonic care coordination in general is not covered. In programs where that's integrated, like in the medical home and you know, kind of other integrated initiatives where coordination is part of the package, the devil is sort of in the details. You have to hire the right people, you have to supervise them properly, you have to give them the right mandate. And there are, you know, often there are challenges in those environments too. A second core component, and Mike Hogan mentioned this specifically, these programs, the evidence-based programs, all include consultation between mental health specialists and the general medical treatment team, such as the patient can be managed in general medicine, which many people can, and in particular consultation that does not involve face-to-face contact with the patient. If there's face-to-face contact with the patient, then the consultation is covered, but as Mike said before, there are still not regular coverage mechanisms for the professional-to-professional consultation that are integral to evidence-based models. A third core component, and I mentioned this before, is outcome monitoring and treatment adjustment in the event of that the patient isn't making progress. Here, too, there are issues of coverage and of accountability. So we don't treat absent biomarkers, which we don't currently have. We don't treat the assessment methods for tracking progress, clinical progress in people with psychiatric problems. We don't treat those the way we treat medical lab tests, and maybe we should. We also, the quality metrics in this area often don't hold providers accountable for treatment adjustment given a lack of progress. And again, that's an important area. So John and Richard and my colleagues here have mentioned many new steps that work in the directions of supporting these care elements for effective integration. But with respect, we can't and shouldn't take for granted that these are enough, as indeed Richard emphasized, neither individually nor collectively. The patient-centered medical home is an important model, but again, the devil is in the details. The same is true for accountable care organizations. Parity is hugely important, but the truth is that we don't do a good job of managing chronic medical conditions using these same principles either, and so we don't want to hold, we don't want to achieve parity by doing no better job for depression or anxiety or other psychiatric problems than we currently do for diabetes or COPD. So I'd like to encourage us all to keep our eyes on the ball of supporting those specific integration models for which we have evidence, and to hold new models to the standard of demonstrating that they are at least as good as the collaborative care models that we know already work. Tom Insel, my director, laments publicly and regularly about the efficacy of current mental health treatments, and acknowledges, even emphasizes, that so far, for various reasons, we don't seem to have much new treatment technology in the pipeline. So the impact model, disclosure, I was one of the principals, not necessarily integration generally, but impact per se, doubles the effectiveness of usual care. And that's an effect size that's within our reach today, and we should all be pursuing.
So I want to thank our panelists, and obviously we're going to move now on to your questions. Before we do that, I'd like to just say, I want to thank all of you for, first of all, being here, but also the administration for its breadth of support of these initiatives through the Affordable Care Act, through the work that CMS is doing, CMMI, SAMHSA is doing, and NIH is doing, and NIMH. It's critically important that the level of attention, I'm sometimes struck by the discussion about the young invincibles who need to sign up for care under the Affordable Care Act, and the reality that the young invincibles may not be so invincible, especially if we look at the greatest risk to young people, which is mental health and substance use disorders. So I think it's critically important from that vantage point that we get this right. Richard, the first question's to you. So what are your thoughts on changing or encouraging new payment systems to pay for integrated care? How do we both take the steps to begin to implement this, but also do it in a way that will allow us to measure whether we're really getting efficacy here and improved outcomes?
Thanks for that question. I mean, two things. A general comment. I think it's a wonderful question, because what it does is it pushes us away from fee-for-service thinking. And in fact, I think we spend too much time fighting yesterday's battle about what's covered and what's not. We've got parity now, and the world is moving on beyond that. And so really payment reform, organizational change is really, I think, the center of what will determine the future. So I think for this community, the most important thing that I tried to emphasize in my remarks was we need to make sure that these payment systems, all of which are aimed at sort of bundling in one form or another and putting more care under a budget, has this sort of offsetting incentive to not only do less, but to do better, and that is quality measurements. And I think that you have to realize that not every single quality measure that the behavioral health community is going to come up with is going to get on the docket, because there is measurement fatigue in the community, and many of you are clinicians and run academic medical centers and things, and that's burdensome. And so there's going to be a balance. And so we need to be smart about developing strategies of how do we identify in a sort of measured, sequential, efficient way who the good guys and the not so good guys are, and then start to tie those things to our payments, our gain sharing arrangements, and the like.
Let me just ask if I could one brief follow-on. So we, in this report, we basically outlined that there's this very large increase in costs associated with medical surgical care costs with individuals who have mental health and substance use illness. And on the one hand, we've got these somewhat separated payment systems. On the other hand, we also know that historically mental health systems have been underfunded, have been rated to pay for other kinds of costs. So there's also a strong feeling that we need to protect and manage the existing budgets in a way that don't take care away from people who are suffering grievously with mental disorders. Thoughts about how we begin to evolve that discussion?
Yeah, I do think it's a dilemma because we've seen both sides of it today. In a sense, the field Monday, Wednesday, and Friday says we need to integrate, and then Tuesday, Thursday, and Saturday say we need to protect mental health budgets, which is exactly the opposite of that. And so I think there is this dilemma, and underneath it all is a conversation about carve-outs. I think the best thing to do is to create accountability systems that are organization neutral. And if you can hold folks accountable for doing the right thing, then you're going to be somewhat less concerned with whether it's organized as a carve-out, which has some advantages, or organized as fully integrated entity, which also has advantages. So I think the important thing is to make sure that our incentives and our measurement and our accountability systems are just rewarding folks for doing the right thing no matter how they get there.
Eleanor, a question about SAMHSA. It says, does SAMHSA have a role in bridging specialty mental health practitioners with the primary care world?
I think so, and we have technical assistance programs to do just that. We have, as I mentioned before, the Center for Integrated Health Solutions, which is working on this from a number of different angles, not only training for clinicians to be within primary care settings, but also information on models for financing, models for training within residency education, within education for other types of health practitioners who are equally as important to all of this: nursing, pharmacy, social work, counseling. Our technical assistance programs address all of those different groups and try to bring together these groups towards a common goal, which is to better serve patients who so frequently have these co-occurring disorders.
Great, thank you. This is for John. So can you speak a little bit more about the different opportunities and challenges that are faced by integrated care in pediatrics and pediatric primary care? We've talked a lot about the collaborative care models, which have really been studied much more in older adults rather than younger adults, mainly in depression rather than other conditions. So I wonder if you have some thoughts about that from CMS's perspective.
I do, and this is where sometimes statute gets in the way of trying to do the right thing, but part of our experience with health homes has been the struggle that as the state brings up a health home, they have to do that across the lifespan. And so I think some of our early health homes were struggling with how to address and develop a model that, frankly, they were looking for or looking to apply for the adult populations to the children's population. So it's a little ironic that, of course, the primary care medical home started with kids, and we're struggling with it on the health home side. That being said, we've come up with some ways to be able to do some workarounds to that particular provision, and we're also looking at other ways to be able to have states come to us with children-specific proposals as it relates to those chronic conditions that I identified. The one struggle that I will just mention, and it keeps coming up both at the state level and at the federal level, is how to do good integration between primary care and mental health services for kids in foster care, especially those kids in foster care who have experienced trauma. We know that kids in foster care do have a high use of antipsychotic medications. While we want to try to address that, and frankly there's something in the President's 2015 budget to try to address that, we're certainly at a little bit of a loss of how some of those kids, many who don't have a severe emotional disturbances, can fit into this household model.
Thank you. Mike Hogan, there have been a couple of questions about electronic medical records and privacy, and also about how hard it is sometimes, given stigma and other issues, for people to disclose to their practitioners, especially in the throes of other medical conditions, their mental health histories. Just thoughts about that. I mean, both the importance of electronic records, but also the challenges of, these mental disorders, substance use disorders, are among the most intimate of human conditions. They get about as close into the sense of self as any conditions can. So it's a particularly sensitive issue at lots of levels.
Well, a couple of thoughts. One of those is that it seems to me that there are two answers to the problem, and one of them is decency and common sense in dealing with these personal issues on the part of the clinician or team. And the second is HIPAA. And the rules of HIPAA combined with decency and common sense solve the problem. Were it not for the fact that the separate mental health system and the separate health system have grown up with different electronic solutions. So for people providing care primarily in the mental health system, there are a whole different set of software products produced by different companies that are inadequate to address the medical care needs. And the truth of the matter is that significant psychiatric problems are not attended to adequately in the great majority of mainstream health information systems. Now, when people do the work to bring those things together, it works fine, combined with HIPAA and common sense. So one example that was brought up was this idea of having some kind of a measure of mental health wellness or progress or status. Let's say a PHQ-9 score, and treat that as a lab test. So it's a measurement, it's a reliable measurement, it's a real measurement as to how well people are doing that can be treated in the medical record the same way as other conditions. So I said, as I said, that with HIPAA, following HIPAA's rules and guidelines, and decency and common sense will solve the problem. The real challenge is the historically separate nature of the IT solutions. And when they're brought together, it can go fine.
Because one of the great challenges, I think, going forward, I mean, we have lots of initiatives that are going on. CMMI has initiatives, SAMHSA has initiatives, CMS in general has initiatives. We have got private, public initiatives across the country. We've relied for a long time, for example, in the Milliman report, a lot of that comes out of claims data, which has certain limitations. We are increasingly going to be used data that comes out of the electronic medical record, which has its own challenges. But on the one hand, we've got these long-standing issues of privacy, stigma, and the challenges of dealing with this in a respectful and compassionate way towards individuals who are suffering. On the other hand, if we don't find a way to incorporate this information, we will begin to have data sets that are flagrantly, just basically inaccurate, and miss the opportunity and the challenges that we face. So I think that, as we think about the evolution of all of these pieces, I think it's critical that we also remember that there's an evolving data environment that is changing as well. So we are out of time, and want to thank you all very much for your participation. And we're going to now turn this to Dr. Lieberman and the second panel. So Dr. Lieberman, if you'd come up.
Are we going to use the hand mic, or are we going to turn this up? Okay. So we are going to move to a second and final panel. In this case, we're going to try, so in the initial panel, that was really I wish everybody had had like a half an hour to talk instead of 3 minutes to talk, but that was an incredibly enlightened discussion from a variety of perspectives about integrated care and its potential ramifications clinically, economically, practically, from a kind of a systems policy level. We're going to cone down, so this was like a Google Earth satellite or image. We're going to cone down from the 20,000-foot level to closer to the ground and hear the perspectives of some individuals that have expertise and enlightened views about this from different relevant areas within the healthcare system. And to do that, I'm really happy to welcome our panelists, including Dr. Henry Chung, who's the medical director of the Montefiore Accountable Care Organization, associate professor of clinical psychiatry at the Albert Einstein College of Medicine, Dr. Frank Degree, who is the Woodward Chisholm Professor and Chair of the Department of Family Medicine at the University of Colorado, Dr. Karis Myrick, the President of the National Alliance of the Mentally Ill, of Mental Illness, National Alliance of
Mental illness.
National Alliance
On mental.
on mental, just
Illness.
like my text says. And I want to also thank particularly Dr. David Bromberg for stepping in on relatively short notice to participate. Dr. Bromberg is a general pediatrician practicing in Frederick, Maryland, and he's credentialed in behavioral and developmental pediatrics and serves as the district chair of the American Academy of Pediatrics Mid-Atlantic region and is on the board of directors there. So thank you for all for being here. We're going to begin with the same format. Ask each panelist to make some introductory comments, limiting it in time to a couple minutes, and then we're going to take questions from the floor. So Henry, would you start us off?
Great. Thank you, Dr. Lieberman, and thank you, the American Psychiatric Association, for inviting me and giving me an opportunity to talk about an area that is so passionate to me. I'm currently at Montefiore Medical Center. Montefiore Medical Center is an academic medical center in the Bronx County of New York City. And I guess you could describe the Bronx County as a large safety net population. 50% of the county has Medicaid, and Montefiore has been serving that population for a very long time with a passion for bringing in treatment for behavioral health disorders. But with the advent of the Accountable Care Organization, of which Montefiore is a part of that movement, and taking responsibility for the care of that population, and by accountability, I mean both cost and quality, that we have to be attendant to that and to look for opportunities to coordinate care, because we're convinced that if we do that well, we're going to do right by our patients, the people we serve, and also do right via the stewardship we have over the healthcare costs. Behavioral health integration is a key part of the accountable care strategy at Montefiore Medical Center. And I would describe that in the following way, that there are multiple pieces of integration that need to be attended to when you're talking about a large population. First is you want to employ the collaborative care model, the impact model, if you will, in every outpatient general medical setting, and we are striving to do that. We also want to embed primary care and wellness services in traditional behavioral health settings because of the data that suggests poor access to medical care. We now also want to embed this type of integration in our care management models. Our care management models, or case management models, if you will, are for those with the most complex illness, the highest cost, the greatest difficulty being loyal or being managed in a continuous care process. We've been fortunate because we have strong leadership and we have great momentum in all of these different sectors. Here's an example of how this might work. In one of our major primary care sites, we have a patient, this is a prototype patient, who has diabetes, high blood pressure, chronic pain disorder, who has been using the emergency room quite frequently because of difficulty managing her blood sugar. And her primary care physician has been frustrated because after multiple attempts to refer the patient to traditional behavioral health, she's been unable to really stick with that process. And meanwhile, she is clearly cycling down a road of chronic kidney disease, high cost, significant suffering. What we were able to do in this situation is to apply the collaborative care model where a social worker meets with the patient right then and there, referred in a warm handoff, to assess the situation and to look at what can be done. We apply the PHQ-9. We're using other metrics like an anxiety scale. And not only did she have depression and anxiety, which was untreated for a long period of time, but she also has trauma issues, which has not been uncovered until the time of this assessment. We were able to have a psychiatrist not see the patient, but coordinate that treatment plan with the social worker and provide some psychopharmacology recommendations that the primary care doctor can quickly act on because they have the knowledge that a psychiatrist has reviewed this. And although many general physicians use antidepressants, they are wary about optimizing the dosage or thinking about side effects. This social worker provides then the safety net through ongoing measurement using the PHQ-9 and the GAD-7, and even an alcohol measure, to find out how she is doing over time. And here's the interesting thing, is that even though I talked about psychopharmacology, our data suggests that in this type of prototype patient, that 60 to 70% of them opt for some form of counseling, that they would prefer to do that rather than go with the medication option. And so this patient was given the option of both face-to-face therapy as well as phone-based therapy. And in fact, she opted for phone-based therapy because this would be easier for her in terms of our ability to navigate this care plan with her. So that's an example. The satisfaction data we can point to is that we had a goal. We want to educate patients like this about the relationship between their physical health and their psychological well-being. And in our data, our satisfaction data, the suggestion is that over 90% of them have a much greater appreciation of how these two areas impact these kinds of chronic conditions and what their role is in terms of optimizing their health care. But there are challenges, and I'll end with this thought. The first is that there are tremendous psychosocial issues. And the collaborative care model, as powerful as it is, must account for concrete services and delivery of those services. And we need our behavioral health colleagues, our field-based colleagues in the community to work with us on that. And the second is that the collaborative care model is only as effective as your ability to remain faithful to it, to maintain fidelity. And quality measurement around fidelity is absolutely critical in terms of making it work. So we all have to be honest with ourselves about where it works and adjust treatment, and where it doesn't work and think about the additional resources we need to bring to bear. Thank you.
I just want to comment and maybe plant a seed for questions in the discussion to Richard's point before when he talked about incentives. So being in the New York area, I've been aware of Montefiore's really leadership and innovation in pursuing this way in advance of most healthcare, particularly academic healthcare systems. So a question that I'd like Henry to address subsequently, and again gets back to the issue of how do we incentivize systems to move towards this. Why did Montefiore sort of move forward in this way in advance of their peer institutions? So Dr. Frank Degree has been a major figure in the family medicine field and has thought long and hard about these things even before collaborative care became kind of a trendy topic to talk about. Frank?
Thank you. Yeah, I'm glad I lived long enough to see this day. It's been a long time coming. I really appreciate the American Psychiatric Association and Milliman and the people who spoke so far this morning, who are developing progressively refined and evolved understandings of what it takes to give good care. I'm going to just make a couple of comments from the primary care side of the river, just to kind of give you a look into what that world looks like and how it's operating right now. About a decade ago, particularly in the world of family medicine, I mean, we tumbled to the fact that a different kind of care was necessary if we wanted to be any good. If primary care was going to work, if it was going to do good in the world, that it needed to be rendered in differently than it up to that point had been. And all kinds of stuff happened. The chapter heading is Health Homes, Patient-Centered Medical Homes, a form of care that appreciates the need to meet certain criteria. And there's a set of researchers and a body of literature that supports the fact that primary care has value under certain conditions, if it's sufficiently comprehensive, if people have access to it, if it's coordinated, and so on. There's not much controversy about that at this point. There's agreement that primary care is only useful, let's just say, for example, if it's sufficiently comprehensive. And it hasn't been, it isn't. And one of the largest shortfalls in comprehensiveness has been the relative neglect of behavioral problems, mental health care, health behavior change, substance abuse, in the conduct of ordinary primary care, particularly family medicine. So if we want to be in some ways responsible for helping to accomplish the triple aim, if we want primary care to be cost effective and effective, then we need to incorporate into the fabric of ordinary primary care mental health care and behavioral health. So we know that that's going on. We've been dealing with the consequences of trying to make that reach. We have partnerships with psychologists, psychology, social workers, nurse clinicians, care managers, and even community health workers who have certain kinds of special training. And all of that's really good. All of that helps. There's this problem that has been incompletely addressed that is, in my view, from my side of the river, still the elephant in the room. And that is what I call the deep end. There's this certain subset. With adults, it's about 20% of our patients who have mental health, mental disorders or mental health care needs, or who have major health behavior change issues, complicated, comorbid behavioral and chronic disease problems, substance abuse problems, such that I, as a clinician in the primary care setting, either don't know what's going on, but I know this patient is tearing up my waiting room and scaring me because what I'm doing isn't working, and they don't like it, and neither do I. And it's costing a lot of money because they're showing up in unusual settings and not getting good care. Or the problem might be well enough understood, but it's, as some of our panelists made reference to earlier, for example, diabetics and depressed patients can pass a certain threshold of severity where I've tried 2 or 3 things that I know to do that I'm comfortable with respect to managing their depression, not getting anywhere. And I'm thinking the next step is going to require, let's say, using medications that are going to destroy their diabetes control, the deep end. I can keep going. There's a set of problems that represents about 20% of those patients who have behavioral problems of some sort in the primary care setting. where I need psychiatry. I need a psychiatrist. And this goes right to the point of the Milliman report. They kind of talked about the problems that cost us the most, the ones that are the most difficult to manage, the ones where we have the most to gain by doing well. Those are the ones who are in the deep end. Those are the ones who, even today, aren't being managed well. And what it takes in order to manage those well is a psychiatrist partner who's a physician problem-solving, pattern-recognizing partner who helps me put together a coherent, internally consistent personal care plan for the whole person care of a patient. So that's one thing that we ache for psychiatry to do with us, as well as function as a team leader. There's a bunch of behavioral clinicians operating in primary care settings. That team needs some sort of coherence, needs to be rendered effective so that those elements of a behavioral team that are needed at the time are deployed appropriately. We need education. There are certain kinds of problems that if I just knew a little more, I could manage effectively instead of ineffectively. There's a need for consultants and referrals. There are times when at the end of the day, this is not primary care, this does not belong here, help. And having that kind of working partnership, close access so that we can move back and forth across the river under those circumstances is really important. And finally, participating as a system architect to figure out how to design the system so that the incentives are aligned right, so that we don't get defensive and territorial about who's responsible for what. Believe me, there's enough work for everybody here. So that we learn how to share information in such a way that it's respectful and appropriate, and that we learn how to flexibly move into the circle of the active team for patients, in and out of that participation and active contributions to a personal care plan as the severity of patients' problems rise and fall according to the effectiveness of our care. So I'm really glad to see us coming to this day. This feels really good to me. It feels like the most important missing piece of what we need in rendering comprehensive, integrated, coordinated, effective primary care is right at our threshold now. So thank you.
Well, as we said, Frank has been saying this for a long time before it became fashionable, but I think we can genuinely say that the APA in psychiatry hears you. So, Karis Myrick, Karis, maybe you'll share with us sort of your thoughts on this approach, particularly from the perspective of consumers and family members.
Sure. So first of all, I'd like to thank the APA for their work on this and work on integration and inviting NAMI and myself to speak. So this is a very personal issue for me because when I first started to work, and by the way, I'm going to have to read a little bit because I will go off script. So keeping me kind of in the box. So when I first started this work in mental health about 6 years ago, I wasn't on the job long before I was receiving emails about colleagues and friends who had passed away. And these were all peers, people living with mental illness, and they were not much older than myself. The statistic about people with mental health diagnosis dying years earlier than the general population, as much as 25 years, was no longer a statistic, but they were people, they were peers who were advocates, providers, families, and friends to myself and others. And lucky for me, I was approaching my 50th birthday. Yeah. So I knew that, I didn't want to be a statistic or be the fate of what I called at the time the Manderscheid or Druss statistic from their research about mortality rates of people diagnosed with serious mental illness. Further, I didn't want any more of my life stolen or lost due to disability, distress from symptoms of my illness, side effects of medication, and or evading the doctor to assist with identifying preventable and treatable diseases that were stripping the years off of my life and the years of my friends. So I'm very fortunate as the president of NAMI, of the board of NAMI, and also a CEO of a large peer-run organization. I have the ability to learn about these issues related to our whole health care, which includes integration of mental health, physical health, and substance use disorders, and share this information, advocate for integrated services that are person-centered and driven, holistic, culturally based, and influenced, recovery-oriented, trauma-informed, and of course effective. In 2011, NAMI did a survey of the field and working with an interdisciplinary team published several reports about primary care. One was called the Integration of Mental Health in Pediatric Primary Care, and another was the report on the family experience with primary care physicians and staff. And of note in these reports, the family feedback was focusing on creating welcoming environments, inclusive of having resources in the lobby and information in the lobby of mental health and wellness to sort of normalize the whole thing and not have it be sort of that secret thing you gotta whisper. Having access to a variety of resources and supports for family and children, and the needs for pediatricians and primary care providers to inquire early and often about the child's feelings and behaviors and how they are doing in school, with friends, and in their communities. Further, that follow-up must follow if needed and care taken in gathering the information in ways that children and families will be comfortable sharing the information and hopefully in reducing stigma. What I hear from my peers is that people with personal lived experience of mental illness is that they want to be treated as whole persons rather than being seen and treated from the neck up. So we say that we'd like the recognition and desire to be treated from the neck up, down, and all around. There are many of us that wish that all of our needs, inclusive of physical health needs, can be addressed in community mental health centers where records, information are readily available, where they feel the providers, inclusive of psychiatrists, nurses, peer providers, and wellness coaches, they all know them. While we have others who look forward to a team approach of primary care with mental health care done in a seamless fashion without judgment and focused on the person's identified goals for their physical health and whole health wellness. And they also are interested in learning self-management and wellness management techniques. We hear from others, from peers and families from various communities of color, where they consider their primary care physician as the place for their whole health care, as they are reticent to access mental health care in the community due to shame and stigma. Also, peers and families have fears about primary care's ability to see the individual as fully human, which may result in perceiving information through the filter or lens of a diagnosis or symptoms. Therefore, some peers and families are reluctant to share their mental health information with their providers. So we have a working definition of recovery from SAMHSA, which says, that was done in 2011, that says recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And there are 4 domains of that working definition, which include health, overcoming and managing one's disease or symptoms, and making health-informed health choices that support physical and emotional well-being. Home, having a stable place to live. If you don't have a safe place to live or a place to live at all, it's kind of hard to follow treatment. Purpose, having meaningful daily activities and independence and resources to pursue them. And community, which is social relationships and social networks. Under the health dimension, I think definitely within healthcare reform, ACA, and integration environment, the major dimension of health within the working definition of recovery is supported and can be operationalized through person-centered and driven care that involves shared decision-making, holistic approaches, and further with the projected newly insured that may stress our already overburdened resources, partnering with paraprofessionals, peer providers, certified peer specialists, wellness coaches, recovery coaches, system navigators, promotores, add them all in there, along with utilizing the strengths of our community's natural resources for integration and improvement in the health and mental health for everyone. And I think it's possible, actually I know it's possible because I did it. I did celebrate my 50th birthday. I do live in Los Angeles, so you can guess where I went. Where'd I go? Disneyland, thank you. So 15 years prior, I had been to Disneyland for my first visit as an adult, and I declared that I was the saddest person at the happiest place on earth. Several days later, I was committed to a psychiatric hospital, and I sat in my room, and I was unclear about what my future would be. I had gained a tremendous amount of weight from the medication, which inhibited me from exercising, being social, and had me very worried about developing diabetes and other metabolic syndrome disorders. By partnering with my psychiatrist and my primary care physician, a nutritionist, walking in my community, and biking to the beautiful Huntington Gardens and libraries every day, I did recovery. I lost much of the weight, still have a little ways to go, and have celebrated a few more birthdays past the 50. So it will take a team approach, as APA has demonstrated today by bringing everyone together, and the person receiving services must be an integral part of that team. So do you guys think we can do it? All right, I do too. Thank you.
Well, Karis, thank you for those comments, which not just addresses sort of your thoughts about integrated care, but goes well beyond to what comprehensive services are needed for mental health care. It reminds me of hearing Mike speak repeatedly about, it goes well beyond just what happens, when you're in the clinic or you're in the office or you're in any kind of mental health setting. David, so primary care extends across the life cycle, and a key part of it, in fact, maybe the best opportunity we have is to identify and act sort of in childhood and adolescent years. Could you share your perspective with us?
It starts with pediatrics. I want to thank the APA for the invitation to be here and to sit here and give you the perspective from the child's chair. We not only share initials with the APA, but also a commitment to mental health and mental health issues for children, adolescents, infants, children, adolescents, and young adults. The Academy has been very active in interest in the field of mental health for probably at least the last 10 years as well. That it started with several facts, and the facts were already elucidated by the panel in several respects. One is that probably 20% of kids in the U.S. have some significant mental health or substance abuse issue, that only a quarter of those kids at most get diagnosed and treated. Dr. Hogan mentioned the entry into mental health issues beginning in childhood, majority beginning by adolescence, and the identification of those kids being so important. The other facts are that there's going to be an increasing demand for mental health services, and in pediatrics particularly with the paucity of child psychiatrists, that the availability of psychiatric help for kids requires that we take a lot of that burden in pediatrics and in primary care. The primary care setting really is an optimal place for all the reasons that have been mentioned in both identification, early intervention, counseling, guidance, and coordination, and chronic illness management, and enhanced access to outpatient mental health services makes economic sense, the whole purpose of the meeting today. So I think the Academy started with those 4 facts, and based on that, developed 3 principles. That families and children need access to mental health screening and assessment and a full array of mental health services in a medical home, that primary care clinicians in a medical home must be recognized as a portal of entry to mental health services and to the identification of behavioral and developmental problems in children and adolescents, that primary care clinicians and families must have continuous access to consultation within the broad mental health community, and that lastly, payment for assessment and treatment for mental health problems must be adequate and comparable with payment for other issues. So what the Academy did was 10 years ago, they made mental health one of the strategic priorities as part of our strategic plan. They developed a mental health task force that's been active for the last 10 years. The task force has developed a mental health toolkit, and the mental health toolkit was designed to address 2 major issues. One was practice change and what practices might need to be able to be adequate medical homes for mental health issues. And secondly, the toolkit was a compendium of information about pediatric implications of mental health issues with an educational component. Furthermore, as part of our continuous professional development, we've had an active mental health track in all of our continuing education meetings, to be able to give pediatricians the tools to deal with mental health issues on a primary care level. That is part of the work of the task force, that we've developed a very active website, and we have lots of access to successful programs that our members can look to and go online to see what some of the successful programs have been. A major direction that the task force has taken has been the idea of co-location, and we have a list of a dozen or so positive co-location programs. In September of this year, we had a webinar with our PPAC, which is our Private Payer Advisory Council, to look at both the implications of co-location, effective methods of getting co-location into primary care offices, and looking at some payment strategies, working with some of our pediatric councils, which work with some of the insurance companies, to see if we could start addressing some of the issues of payment and cost for these services. That on a state level, that many of the states have tried to put in place some consultation models. I think this has been based on the Massachusetts model. Maryland has just started a BHIP program, that's a behavioral health integration in primary care program, where psychiatric consultation from a child psychiatrist is available by telephone 24/7. I think within 24 hours of the demand. So you see a patient in your office with an acute problem, and that you can get support from a child psychiatrist in both the initial management and the disposition. Information about medication, information about treatment course, support in doing what you want to do in primary care, as well as availability of research. Well, they'll help to identify and get resources for you for treatment of that patient. The 4 components of that program is phone consultation, the primary one, continuing education, research and referral networking, and social work co-location. The program is a jointly sponsored program from the University of Maryland, Johns Hopkins, and the Salisbury State School of Social Work. And lastly, I want to mention Bright Futures, which is the pediatric tool for the delivery of primary child health care, of primary child health care. So when you come in the office for your visits, and the structure of that visit is outlined in Bright Futures. It gives us our periodicity schedule and gives us information and services that children require at each of the visits. And it looks very broadly at health issues, so that it looks at developmental issues at each of the visits, it looks at psychosocial and mental health issues at each of the visits, as well as the medical issues at each of those visits. And there are a number of screening tools and things to support the clinician in delivery of primary care mental health as part of comprehensive well-child health care. From my own perspective, I've had the opportunity twice in my practice years to have co-located services. We had a developmental psychologist with us for several years, going back a little while, and more recently we had a social worker as part of a project to identify the precursors of child abuse. So we did a 9-month-old questionnaire looking at issues of domestic violence, family substance abuse, food insecurity, and depression. And based on that, had a social worker with us in the office who was able to identify those issues as they came up. Both of those experiences probably were the best practice opportunities I've had, feeling the most complete and accomplished at trying to do what we were trying to do in the office. One was grant funded, and obviously the grant funds are gone. But they're great models and great opportunities. So I'm thrilled to hear the implications for primary care, the implications for pediatrics, and the work that's been done by the American Psychiatric Association. I think that there's hopefully a future, and we're all going to have a chance to live and to see.
Thanks, David. We're running short on time, but I do want to try and squeeze in a couple of questions. And first, I don't know if it's me, but it sounded like Frank was portraying a situation where, general primary care and family practice was not sort of as well, had not responded, it was not as sort of well equipped to deal. And it sounds like pediatrics is really mobilized, but my sense is there's still a tremendous sort of unmet clinical need and lack of adequate integration. But I don't want to put words in your mouth, but Frank, is that do you think there's a disparity between adult and pediatric, or it's just that David was painting it in a rosier picture than it may actually be?
Well, I was painting a picture of the steps that we're taking. We're taking those steps because I think the clinician is not ready to handle. They don't have both the information, the ability, or the courage, if you will, to handle a lot of primary care mental health. So I think that pediatrics has always been a prevention-oriented specialty. We've always been very developmentally oriented. So some of the things that I've talked about, we've done for years, and I think all pediatricians are comfortable doing it. As we broaden the definitions and ask more and more mental health capability from primary care pediatricians, I don't think they have all the skills. And this was a response to that fact in trying to do an education program, the mental health toolkit, some of the programs that have been put in place, and to give them those tools.
Frank, do you want to comment?
I think the difference between how behavioral and mental problems in the pediatric population and the adult primary care population are managed have some important differences. They do. They have some important differences. I described about a 20% of behavioral problems in the deep end. That's for adults. If you go to family practices and look at what's the deep end for kids, it's probably more like 50, 60%. Those patients scare us more. I would say that there is more in common. I don't want to minimize the differences between the pediatric problems and pediatric issues in adult. They're important differences, and we need to respond sensitively to that. But the world of primary care, whether we're talking about pediatric patients, young adults, old adults, shares a lot in common in its need to produce comprehensive coordinated care. The details are different, but there's so much in common. I think the message that I would like to leave is that we're all moving in different areas. There's not an enormous discrepancy between how we look in the world of getting it right for kids and how we look in the world of getting it right for adults.
Henry, can I just ask you to respond to the question I posed earlier, which is why did Montefiore sort of really get out in front and innovate here? And also in this context, there was a question about what kind of adaptations or measures need to be taken to address cultural groups, particularly the Hispanic population where English might be a second language.
Absolutely. I think Montefiore's journey on this is very early in terms of looking at it from the standpoint of equity, to be perfectly frank. You know, when you think about the complexity of the patients that we've been serving in the Bronx for such a long period in time, clinicians were very aware early on that we had to have an approach to behavioral disorders the same way that we had to medical disorders. So the early attempts were, quite frankly, things like, you know, basic co-location or trying to fast-track referrals and to create better access systems, if you will, through our Department of Psychiatry and our community partners. And we developed different kinds of incentive mechanisms internally to foster that kind of access. So for example, if a patient is in our network where we take some form of financial risk for that patient in our health plan relationships, they have virtually no problems, should they choose, to access formal behavioral health care in usually 7 to 10 days or less, which is unheard of if you think about it in our network in the Bronx, where we have a voluntary network of physicians. But even that was not enough, Jeff, because as we all know, many of our consumers and patients prefer to receive some form of behavioral health care in the setting in which they're most loyal, in the setting in which they're most comfortable. So developing that option started off with co-location with, quite frankly, the outgrowth of the federally qualified health centers, who really took the early lead in this. So we have federally qualified health centers, and they started that model, if you will, but that wasn't enough. And part of the advent of the ACOs, if you will, is that now that we're joining the payment streams between the traditional sort of behavioral health carve-out, taking that away, putting that into the entire pot, we can make more rational choices. And now we can look at our network and say, wow, where is the population that has the highest cost and the greatest utilization with the behavioral health needs. And we're going to put resources right into that, both field-based as well as, I call it sort of care management-based, that's hovering over the entire process. But clearly, we're in a time where payment alignment and payment reform is going to be the impetus for us to move quickly on this front.
Right. No, the economics are clearly driving it. It would have been good if we had done it on our own initiative, but this is going to make it happen. So just on this issue of location, Karis, so I'm going to pose it. It doesn't have to be an either or, but I'm going to pose it that way just to frame the issue. So would you rather receive your primary health care in the setting where you see your mental health care, or vice versa?
Well, I'm a busy lady, so having it in one place would be great. But I think where the person prefers to have it is going to be a couple of different things, as I've heard. Is some people prefer to have all of their health needs in the mental health care setting. Others prefer to have it the primary health care. Some people don't want it either. And I think we have to be really careful of starting to duplicate things that are in the community that can help with health